So without any hesitation, let's start. Where to land the stent? There are many people that are very well known, but other people, they are questioning. We were talking about the normal, but how frequently is it to get a normal, totally normal section? Ziad.
Sure. Pretty unusual to get a totally normal segment. And of course, what we don't want to do is take a 15 millimeter lesion and turn it into a 60 millimeter stent because we're trying to find normal. So what we want to do is find the most normal in the shoulders of the lesion.
Acceptable, not acceptable to land the stent here, Ziad.
Absolutely acceptable. And important to understand that the measurements can actually occur in 2 dimensions because in this situation, the artery is not perfectly circular. And so what will happen in this situation is we like to take the mean measurement.
What about this, Ziad?
So here's somewhere I'd be looking for a better area. Why? There's a thin cap fiber atheroma. I really have a very large lipid pool. The chance of dissection is considerably higher, and I don't actually see 180 degrees of external elastic lamina. And so we know that this has a higher risk of dissection, and so what I would be doing here is perusing the artery by 5 millimeters to find perhaps not the completely normal segment, but a more normal segment. Well, what about you, Giulio? Are you happy to land into fibrous tissue?
Absolutely, yes. We can measure, and you can just dot the EL, and then you can trace in the both diameter, very important. What about calcium? How much is important the lumen area? Because we are detecting calcium automatically. You can see what is important to get when we have a calcium in front. Ziad.
I think critical to understand that what the lumen area is, because often our segment where we're going to be using lumen-guided stenting is going to be calcified. If you gave me the choice of this guy or this guy, I'm taking this guy, notwithstanding the lumen. The reason, lipid is like tissue paper on top of toothpaste. If you tear it, the lipid will come out. Tearing this artery is much more difficult than tearing this artery.
Super.
Let's
say the EL versus lumen. But there are no patients with EL, a patient with a lumen. there is a mixture. So what should be done? Safe here, safe here. What do we need to discard in terms of landing?
Let's poll the audience. How many say A? Hands up. Hands up, come on. How many say B? Okay, so we have some work to do. Okay, so what you have in B...
That is very important. This is essential of the imaging, the essential of the baseline. Go ahead.
So remember, one of our characteristics for stent sizing is we want to find 180 degrees of external elastic lamina. Why do we do that? It's only because the amount of visible EL represents normal. You can only see the external elastic lamina in totally normal or fibrous tissue. And as Giulio mentioned, that's the perfect place to land your stent, either into normal or on a pillow. Here, you have a lot of lipidic plaque, a relatively thin cap with very little external elastic lamina. And as a result, you're more likely in this situation to create a dissection. Rather here, we're able to measure EL to EL, and actually, we have a large area where we're actually able to measure from.
What to get from this longitudinal view and a cross-sectional view?
Well, I love this because it's real life, right? So I give a lecture on OCT, artificial intelligence, which reminds us that we need artificial intelligence because while MLD Max in its glory is very simple, real life is complicated. And this is the type of lesion that you get, right? So we have a lipidic plaque with some external elastic lamina. Here we have a large fibrous cap, but some signal attenuation. This is largely the area of necrotic core, another area of necrotic core, and then we have to land at the ostium.
What about the landing zone? What about the carina?
Absolutely. So what are the information that we can get from the carina? Are we going to stent across? If we're going to stent across, we need to look at this angle. Is it less than or greater than 50 degrees? And also the carina to tip angle. 1.7 millimeters is an independent predictor of carina and plaque shift. All of these things can help you determine whether or not we should be trying to stent across or try to find a normal landing zone.
So suppose that this is your patient. What you wanted to do? So based upon the type of plaque, based upon the position.
So here I'm going to be making an external elastic lamina to external elastic lamina measurement. This is all fibrous tissue. I'm going to direct stent this. It doesn't need any advanced lesion preparation. And in this situation, because my angle is short and my carina tip angle is also short, I would be planning to land my stent at the ostium.
How much are you confident to land at the ostium of the
Great
LED?
question. We know that even using the most accurate co-registration, there's a possibility that I'm going to be landing some stent struts across. However, I can see that my circumflex is actually very large, and it's a clinical decision based on whether I have enough space to perform a proximal optimization technique to determine whether I should be stenting across or stenting up to the ostium.
So suppose I'm changing my color. Suppose that your stent is more protruding. What are you doing?
Well, in
Or
general,
more protruding again?
very possible. It's very possible. And this is a potential problem with stenting across the ostium. However, like I said, what really needs to be done here is to make sure that you have enough room to perform a proximal optimization. Because right now, according to my visual inspection by OCT, we have probably about 5 millimeters or so before we get to the aorta. And so I may or may not want to stent right to the ostium. I also need to think, what size stent am I going to be putting here? Is this a 3.0 that I can't take to 5.5? And I might only be able to take to 3.5 where I mangle my stent and elongate it. And then, Giulio, I'll have the same problem, but then it'll be in the aorta.
Absolutely. Let's talk about this type of images where you have multiple components. There is any volunteer that wanted to come to the smart screen to tell us? Otherwise, where are the essential components?
All right, come.
Arun, you are biased. We are taking an expert guy. That is not in the rules normally.
But the calcium is not 180 degrees, not a problem actually. The stent will expand. And we have some calcium, maybe deep calcium here.
Calpri plaque.
Tell us about, what do you think about the shape and the form of this cap? Why does it look like that?
This is a heel plaque.
Yes. Correct. Very good. Comments about the ostium? You have a lot of segment of calcific disease.
Yeah. So it's a deep calcium.
So,
Maybe one IVL or something.
okay, and the angle is this one. IVL. Rotational?
Why? The other important thing to always note is the more superficial your calcium, the better the impact of atherectomy-based devices. If you have a covering that's like a pillow on top of a plate, when you put a pillow on top of a plate, if you use a drill, it won't hit the plate. What you need to do in that situation is think about things that squash the pillow, like a balloon where you can deliver lithotripsy.
Oh, yes. I think yes. We've spoken before. Eccentric position, the corresponding cross-section. Can you show practically which is the risk to have a misinterpretation We heard about artifacts, and when you have a tangential position of the catheter. So in this case, what do you have to look at?
No.
Okay, so how to solve the problem? Here we have a single frame, but we have a longer sequence of multiple frames. You are going neighboring frames.
Absolutely. So artificial intelligence applied to human intelligence. The beauty of a longitudinal stack of images is that there's information in every direction. So when we see something on a screen and we're going to be making a clinical decision on it, it behoves us to move just before and just distal to ensure what we're looking at is what we really think it is.
This is valid for many situations. Eroded plaque, something that is not standardized, and you can be in trouble. You see sometimes that could be eroded. You move back and forth for clarify which type of plaque is.
The most common misdiagnosis of erosion happens because of blood speckle. Because when the light hits the speckled blood and then hits the wall, it gives the appearance of an erosion, but actually the artery is completely normal.
Attribution of the major components. So you have two different plaques, cross-section, you have a pen, you need to say what is this plaque, what is this plaque. You have two cross-section. So let's make the interpretation. You have a lipid, you have a fibrous, you have a calcify, and you have a quadrants. Fibrous? And you mark for all the quadrants, means they are all the same? Which one is lipid? Okay. Where there is the L, where there is not the L? In this image? Okay. Okay. So essentially, in this quadrant, there is no EL. One that was explained before by Ziad. So here we can see the EL. There is a mixture of a segment with EL with not, based upon the visibility and based upon the penetration of the light or the attenuation. We are making interpretation of what to lend our stent, what is safe and what is not safe. One single cross-section. Here you have a culprit and a non-culprit lesion. And let's try to get some information. Who is coming? Please come.
So just
which
show
is
us
the culprit,
culprit
and what is it?
Which is the culprit and why? Only one of these cross-sections is the culprit lesion.
Super.
Why?
Is a rupture plaque?
Right.
And then you have some thrombus. What about this one? Okay. What about this one? Can you land safely or not here? Thin cap. Thin cap means thin cap here, and you can measure, of course. What about this one? This is fibrous? No. Macrophages, because macrophages, Ziad? What about the attenuation? Do we have the classical attenuation from the macrophages? The shadowing. Normally, you have a shadowing when they are intense signal that might be also cholesterol.
And how do you differentiate between cholesterol and macrophages? So this is simple to remember. Cholesterol is a crystal. A crystal will allow a light to go through it, but a macrophage is a cell with DNA, etc. It will not, it will attenuate. That's how to differentiate between cholesterol and macrophages.
Thank you very much.
So question on this frame. Let's stay here for just a second, right? So the lesion ends here. Here. Do we put a DES here? Or do we cover this lesion? But this is intermediate.
So thin? I'm not sure that is so thin.
Is it vulnerable? Is it?
No. Who say the no? Stand your hands,
Hands up. No, not vulnerable plaque.
No vulnerable? Who say that is a vulnerable plaque? And all the others stay silent. Come on, guys. We needed to have to stand up your hands. Okay.
So let's talk practically, okay? Practically speaking, to leave an area with a minimal lumen area less than 4.5 in the reference segment is an independent predictor, 6-fold increase of hazard. And all we're doing here is elongating our 28 to a 38. You're covering this plaque. And if you think about the entire concept of vulnerable plaque, what we're essentially doing is sealing this cap, getting a lumen area, and promoting fibrosis and healing on this vessel. So that's practical interpretation of. Now, if this was 32 millimeters away, you need to think about it in a completely different light. But practical interventional PCI is to cover lesions that are in the reference segment that have a 4.5 millimeter squared less area.
There is another step that is beside the PCI. You need to interpret the risk profile of this vessel. So in terms of medical treatment, this is a patient not only with a culprit lesion, but with a multiple segment of the coronary artery. They are very prone to be unstable in the future. So that is a second step in your decision making that should be taken.
Sorry? Well, by OCT criteria, it's classically not vulnerable because it doesn't have a thin cap fiber atheroma. But if you were to extrapolate the Prospect 2 data from this, it's get a very large lipid burden. And perhaps if we did an IVUS, I'd suspect the lipid burden would be greater than 70, and then we would say that it is.
3 levels of instabilities. The first one is, who is answering? What is this one? Okay, thick fan. Okay, thin fibrous cap atheroma. You cannot see the EL behind. You can see the EL from here to here. What about this one? Erosion. See, nodule, no. This one is a nodule. This one is a calcified nodule in which you can see the irregularity of the lumen, like white calcium that was broken and became unstable. What about this one, Z?
This signal attenuation suggests macrophages, and an attenuation related to that, this may not even be lipidic plaque, but could be. So from this cross-section, I can't tell. This is not an unusual situation where you have layering of the macrophages and they come in together in a sort of hot plaque. Let's go to the calcified nodule for a second. Is this a protruding calcific nodule or an eruptive calcific nodule, and what's the difference? Okay, so it's thrombus.
And thrombus make what? And make the surface irregular. Okay.
So this is an eruptive calcific nodule. As you can see, it's got a jagged edge, right? And so the pathophysiologist of this eruptive nodule usually happens in the mid part of the right coronary artery, the proximal circumflex, because they have a hinge movement, and the delta between systole and diastole is large. What's happening here is you are having a lipidic plaque that is calcifying. It's not calcified. But due to this torsional movement, at one point, this fractures and creates shards of calcium. Now what happens is those shards of calcium stick into the lumen. They get fibrin and thrombus on them, and they stick into the wall. What happens in the wall? Nothing? What if you take a knife and stick it into the wall? What would happen? Intraplaque hemorrhage. So you have large areas of intraplaque hemorrhage in a lipidic core. This is critical because the eruptive calcific nodule is imminently deformable. If you take a stent, you will push it out of the way. But a protruding calcific nodule, which is a healed eruptive calcific nodule, behaves differently.
Let me see what we have. We are talking about this, I think.
Aha! Wonderful. Okay. Calcium protruding. Now, is this an eruptive calcific nodule or a protruding calcific nodule? Protruding. Why? Is the cap irregular or regular? Okay. This is fibrous tissue, right? This is healed fibrous tissue, and this calcium is not calcifying. It's a marble. Okay? Can you crack a marble? No. You can only push a marble. And so the treatment of the eruptive calcific nodule, which has intraplaque hemorrhage and lipid underneath it, means it's almost always deformable. A balloon pushes that out of the way, a stent pushes that out of the way. But this is not deformable because it's a marble. And this is what frequently will lead to an eccentric stent expansion and asymmetry.
And so if you are growing with your balloon, which action are you doing against this nodule?
What you're essentially going to do is tear the fibrous tissue at the interface of the nodule. The balloon will expand radially. How do you know that? Because of the way your wire behaves in the balloon, okay? So when you see a wire bias of the wire towards the calcified lesion and the balloon expanding radially towards the opposite side, you are essentially tearing the fibrous artery and the calcified plaque is not being modified.
So eccentric nodular calcification, IVL is the question.
Great question. So I just finished the publication, and perhaps I can show you the data later, but I'm going to summarize this. Do we have a blank screen, Giulio? Or I can work
no,
here.
No,
Here,
you need to work here.
here. Okay.
Just to cancel.
All right. So here is the bottom line, guys. There are two types of marbles. Okay? Unfortunately, you cannot see underneath the marble with intravascular imaging. There is a marble. Where can I do it? Here. There's.
You can explain.
Wonderful. Okay, good. Thank you. Okay, there's two types of marbles. There's a marble that still has lipid and underneath it, and there's a nodule that is fully calcified, unidentifiable by intravascular imaging. Hence, the way you're going to make this diagnosis is again by the behavior of the balloon and the relationship of the wire. If your balloon expands and your wire is centralized, this is getting pushed down into lipid. It will deform and move out of your way. If you are having the situation where you have a heavy wire bias towards the lesion and away from the balloon, away towards the other side, this is calcium. This is IVL. This is stent. Make sense? If your nodule behaves on top of lipid, you can push the marble into the plaque and into the lipid. But if your marble is sitting on top of rock, it will never expand. So we have to crack the rock. And actually the IVL works at the edges of the marble, allowing you to facilitate movement.
Okay, as you are seeing, we are moving from morphology to the treatment. Let's have some idea here. Okay, how did we achieve this? How did we achieve this? You have a different type of devices. Here what we have. This is the IVL, and what we have inside this picture room. This is what? Crack, this is what? Dissection? Dissection, this is what? An incision. Can we call this incision just to uniform the term? Incision, cracks, dissection.
Probably these are due to cutting balloon or something. It happens in a cutting balloon, we get such cuts. These cracks are IVL cracks.
Can we be sure 100%, Z?
No, but But I think some of the clues are the distribution of the cracks. So if I had to bet, I'd say for flex.
Correct. Okay, and what about this one?
Well, it looks like an explosion. And
What about the deep calcification in front of very thick calcium?
so this is exactly what I just described to you. When you have the marble on top of a rock base. And so what IVL is just not strong enough to break the nodule, so it breaks the edges of, and so I'm going to go for B. The other trick, by the way, is, let's go back one slide. The other thing that I'm looking for is a smooth, rounded surface anywhere that was the modified segment by either orbital atherectomy or rotational atherectomy, which I can't see. And hence, my answer is B.
Now we have a couple of more segment treatment. So what about this one? What about that one?
Okay.
Rotablation, and this is orbital maybe because it's eccentric.
Which is the difference, Z, between rotational atherectomy and orbital? And then when we have done a rotational atherectomy and we have these type of images, what should be done in terms to take measurements, or is enough because we use a 1.5 burr and we end up the word, or we needed to go more and upsizing the burr or treating with some additional aggressive lesion preparation?
So first comment is your orbital atherectomy system is a 1.25 crown that orbits and gets to a maximum of 1.8. So one trick for you is to actually make this measurement. Now, how big is the OCT catheter? 0.9. This is approximately 0.9 times 2. This is more likely to be orbital atherectomy. Now here, you can see a very smooth surface. This smooth surface is very much consistent with a rotational atherectomy device. Now, Giulio asked a critical question. Am I done here? When does calcium start to fracture after you've modified it?
Demonstrate cracks.
Right. How is this going to crack or no?
The thickness of that, if it is 500, less than 500 microns, then it's most likely.
Absolutely. And in fairness, in this specific case, you're going to crack here. Right? Because actually this is a segment of fibrous tissue between a calcified plate.
Ronnie, we had tons of images, but we have done and we are on time, giving back at the end of this session.
I don't think they want to leave.
I hope you enjoy this type of interaction with us.